Sad story, really.
Okay, it's 8. I think we can start now. Okay, just a quick final audio check before we start. Can someone give me a signal if you can hear me?
Yes, Doc, we can hear you.
Hear you, Doc.
Okay, thank you. Okay, let's start. No, okay. Before we begin, I always open up for all my classes. I always open up with if this were face to face, I'd ask everyone if you have all read the material already. No, but sige lang, we won't spend too much time with the show of hands. But I would advise everyone to please read the material. Don't depend on my lecture. No, okay, there's always an open forum at the end if you'd like to ask some questions. But it's difficult to ask questions and interact on the topic if you have not read the material. So again, I would like to emphasize that all the exam questions will be derived from the textbook. However, to help you out, I'll ask you to watch out for certain cues. No, I have this habit wherein as I'm lecturing, I often say, if this comes out in the exam, or I might say, if you are asked this in the wards when you're interns or when you're residents. No, if this it's usually a cue similar to that one. If you are asked. No? Usually if I ask that, it's important, and 90% of the time it will come out in the examination. Okay. And another thing, even though during the beginning of my teaching stint, no, I really enjoyed making questions to uh, twist questions around and try to trick everyone. No, I've got no, at present I'm a simple-minded person, so don't overthink. Don't overthink the questions when you're trying to answer them. No, what you see is what you get. No? Okay. That said, another thing, I under the 21st edition of Harrison's came out this year, but I understand most of you are still using the 20th. So yun lang, I will clarify regarding, not fortunately for us, the topics that we will be discussing this morning, endoscopy and peptic ulcer disease management. Not much has changed since the last edition, but when I'll be lecturing to you next, there might be some changes there once we reach the topics on liver cirrhosis and portal hypertension, complications of cirrhosis management, no, and alcoholic liver disease. I will keep you up to speed with that. Okay, I've been given 4 hours for two topics, no, endoscopy and the medical management of peptic ulcer disease. Now, 4 hours is really too long. That's the equivalent of 2 movies, no. If people can fall asleep in the cinema watching one movie, two would be quite long, and somebody talking in front of you would be even more enticing for you to just drop out and fall to sleep. No? So traditionally, I do not consume the entire 4 hours. No, I give enough of a condensed discussion with the understanding that you have to read the material. Okay, so siguro mga by 10 or so will probably be done. So most students like that, but that's not the point. It's not to shorten the lecture to save time, but it's to maximize your learning, not to be too dependent on lecture, and to make the lecture effective just short enough. Because even in international conventions, you don't go with a lecture that goes 4 hours straight. No, you get breaks in between and you get to move around the convention hall. Okay, with that out of the way, okay, our first topic will be on endoscopy. I like to start out with scenarios. Okay, so take something that is apart from our what do you call this, from our topic, no, but analogous to. Okay. So you have a hostage situation. You have 6 hostage takers holding 12 hostages, and they are all housed in a windowless warehouse, single story, no divisions inside the warehouse. The SWAT team says, we don't have eyes in there. Okay, take note of the cue. So the current options that they have are, well, they can break the door down and go in with a blind breach. Two, they can just wait for whatever demands the hostage takers have and give into these demands. And C is a question mark. Now, you happen to be passing by and you see the scenario and you remembered my lecture, and you approach the the head of the SWAT team and you say, I used to be a medical student at CDU before I decided to drop out. I remember one of my teachers, I think it was Dr. Garcia, he was discussing endoscopy and he was talking about a UDC. A UDC is an under the door camera, which you can it's an extension of the basic camera essentially, which you can put under the door so that you can see the interior. No, so essentially it's an extension of your eye, which cannot see the goings on inside the warehouse because of the walls and the roof covering the interior. Or I've also seen movies wherein you can crawl through the ventilation shafts and use an instrument which we call a scope to survey the scene from above. No? Okay. Now, this one, scenario B, would be closer to it's closer to medicine. It's closer to medicine, and it's something that you would most likely encounter even at the home. No? So this 58-year-old man could be anybody. Could be your neighbor, your brothers or sisters, your parents, aunts or uncles. No? So anyway, in this particular case, a 58-year-old man comes to see you due to pain in the right side of the face. He says, it seems to be coming from the inner side of my right cheek. Things you can do, okay, among other things, take a good history. This happened, doc, this happened 3 days ago and started with an aching pain on the inner side of my cheek. Okay, you can do imaging, no? For those of you who are in a rush to go to technology for the answers, no? X-ray, ultrasound, CT scan, MRI, no? Have your patient spend a ton of money. When the easy thing to do would be to do your basic physical examination and ask the patient to please open your mouth. I need to see the inside of your mouth. And ta-da! You find out that the patient has an aphthous ulcer. So in Bisaya, in the dialect, it's the giluas ang pasyente, and you save the patient a ton of cash with not spending for an MRI, for a CT scan, for an X-ray, just by doing things right, and in proper order, and that's a good physical examination. Now, closer to, no longer analogous to our discussion, but directly related to what we will be talking about, is scenario C. You have a 40-year-old male who comes to see you for intermittent epigastric burning pain over the past 3 years, despite the use of antacids, which he has been taking on a PRN basis, on an as-needed basis. Doc, I think I have an ulcer. Sometimes they will give terms like, Doc, I have hyperacidity symptoms. Okay, now options for you to verify. Okay, let's say you've done your history, so you can do a physical examination, or again, you can go to technology. You can do an ultrasound, CT scan, and the question mark. What is the correct answer? Now, to answer that question, you have to understand that despite the exterior appearance of the abdomen, it looks like a boring, flat, cylindrical structure. If you're looking at it from the front, it just looks kind of flat. It's only the flatness, the monotony is punctuated only by your major landmark there, which is the umbilicus, and whatever cuts of the abs your patient may have, depending on how fit this patient is. But in truth, if the exterior covering was transparent, you know that it's a big sack with a ton of structures inside, some solid, some hollow. So if your patient is complaining of upper abdominal pain, then there's a long list of differential diagnoses here, among which, well, maybe there's something in the liver. Maybe it's something pertaining to your gallbladder, your stomach, the transverse colon that crosses, among other things. And you have no eyes in there. Now, remember, the scenario is you are entertaining an acid-related problem. So among things, gastritis or an ulcer. Now, that means an injury or inflammation or any break in the mucosa lining of your upper GI tract, and you have no eyes in there. Now, even if you had all the technology at your disposal, predator technology, even if you utilize the entire visual spectrum available to predator technology, nothing will beat direct visualization. If your intention is to diagnose a mucosal defect. And this brings us to our topic for this morning on endoscopy. Now, legend has it that the originator of endoscopy was actually looking at sword swallowing, and he was thinking that doing all this stupid stuff for entertainment, no, surely I can come up with a better way to put in a solid structure into my mouth, down my esophagus, and into my stomach for scientific advancement. And but the actual documentation of development of endoscopy is such. Let me give you a brief history. Of course, if you get a hollow tube small enough for you to swallow, enter the esophagus and enter the stomach, if you take a look inside, you won't see anything. It's dark. There's no lighting inside. So the development of endoscopy includes the development of light conductors and the addition of light sources, both external and then eventually internal, and then later the ability to not just real-time visualization, but the ability to record, the development of the gastrocamera, and the ability to move around inside using flexible tubes that incorporated fiber optics, so that it would no longer be a solid, straight pipe that essentially you'd be poking into the upper GI tract. So endoscopy is now currently the provision of flexible scopes of an electronic video image via a charge coupled device at the endoscope tip. So mainly it involves the skill of an operator. You have knobs that can be turned clockwise and counterclockwise. So your main big knob, turned clockwise or counterclockwise, controls whether your scope is deflected up or down. And you have a smaller wheel that deflects the scope left and right. Now the scope is made up of, you have the operator controls, and the main component is the flexible shaft, wherein you have fiber optic bundles or LEDs that provide light, with LEDs that provide light at the tip. And you have working channels that allow for washing, suctioning, and passage of instruments. So at the tip of the scope, you have your camera lens, and then you have your light source, and you have channels, hollow channels, for passing instruments or for passing air and fluid support, plus channel for suctioning. This is a typical image of an endoscopic view. So the procedures that we will be talking about in relation to endoscopy are your esophagogastroduodenoscopy, or what we call the EGD, also known as the upper GI endoscopy, colonoscopy, flexible sigmoidoscopy, small bowel endoscopy, and the amalgam of endoscopy with other imaging modalities. So ERCP, which is an amalgam of endoscopy and radiography, fluoroscopy, and endoscopic ultrasound, which is an amalgam of endoscopy and ultrasound. There's also a discussion in your chapter on natural orifice transluminal endoscopic surgery and endoscopic resection and closure techniques, which are therapeutic applications of endoscopy. We'll be touching briefly on those. So first, you have your upper GI endoscopy. This is a procedure during which a small flexible endoscope is introduced through the mouth and advanced into the esophagus, stomach, duodenal bud is the first portion of the duodenum and the second portion of the duodenum. Hence the word, the title esophagogastroduodenoscopy. In skilled hands, you can actually extend your examination well into the third portion of the duodenum. So it will look like this. No, you can extend your visualization down the esophagus, stomach, all the parts thereof. You can visualize all the parts of your stomach, from your cardia, your antrum, your body. Your cardia, your fundus, main body, antrum, okay, and then you can visualize also the up to the second or third portions of your duodenum. It is the upper GI endoscopy, or the EGD, is the best method for examining the upper gastrointestinal mucosa. It is essentially direct visualization of the mucosa. In terms of therapeutic value, it also permits endoscopic therapies aside from just its diagnostic value. For comparators with other diagnostic tests, for the diagnosis of duodenal ulcer, it's similar in accuracy as an upper GI series, which is a radiologic procedure. And for the diagnosis of gastric ulcers and flat mucosal lesions, upper GI endoscopy is definitely superior. It would be hard-pressed to find a diagnostic test that is better than what your eye sees. Okay, so this is an example of the contrast between the two. This is directly looking at an ulcer. So just by looking at it, even a layperson can look at it and say, as long as they know what the picture is about, they'll be able to tell an ulcer. This, on the other hand, is a radiologic diagnosis for this is a barium-based evaluation for diagnosis of an ulcer. Okay, if you don't know what this circle is, now you'd have to be trained somewhat in radiology for you to be able to come up with the diagnosis. Okay, so it is therefore the best method for examining the upper gastrointestinal mucosa. The preparation for an upper GI endoscopy involves fasting, midnight, the night before the procedure. That's usually a time frame of about 6 to 8 hours now, because sometimes endoscopies can also be scheduled at different other times of the day. Intravenous conscious sedation may be given to the patient to ease anxiety and discomfort, although there are conditions wherein the patient is not sedated but is given the adjunct of topical pharyngeal anesthesia. There is also the development of newer transoral and transnasal ultra-thin endoscopes, which have improved tolerance. But the general usage now in all of our institutions here is we still use the standard scopes that pass through the mouth and throat. A colonoscopy is a procedure during which a flexible colonoscope is passed through the anal canal into the rectum and colon, with the intention to reach the cecum in more than 95% of cases. So you pass through the rectum, the sigmoid, the descending colon, the splenic flexure, the transverse flexure, ascending colon, reach cecum. I just got a message that my internet is stable. Can you still hear me?
Yes, Doc.
Okay. And in skilled hands, you can actually extend your examination, cannulate ileocecal valve, and do an examination of the terminal ileum here. It is the gold standard, colonoscopy is, for imaging the colonic mucosa, just as upper endoscopy GD is the gold standard for imaging the upper GI tract mucosa. Again, here comparators for colitis, cancer, polyps. The colonoscopy provides greater sensitivity than your radiologic procedure. We're talking about a barium enema. In diagnosing polyp, it's getting stiff competition by CT what we call virtual colonoscopy, which is a CT-based and diagnosing flat lesions such as serrated polyps. Colonoscopy has greater sensitivity than CT colonography. Okay, just to give you an idea of how these things look like, this is an image of a barium enema. So remember, if you look at it, now, the barium enema is a zoomed out view. So it gives you a good picture if you're looking at it from afar. But if we're talking about mucosal lesions, that means you want to see what the inner lining looks like. You can understand why a colonoscopy is superior to such a test. And this is an example of CT colonography. Now, it's creating a virtual image via CT, and you can see head to head with an actual visual finding of a polyp seen in C versus the virtual virtual colonoscopy finding in B. You can get the general shape, you know, but the intricacies of what the mucosa or what the lining looks like is difficult to replicate with the virtual colonoscopy. Now, for the preparation of a colonoscopy, bowel preparation is needed here. So you have dietary alterations ranging from clear liquids to NPO so that your patient does not form new stools, and you will have to employ laxatives to clear out the stools that are already there. These patients are usually administered intravenous conscious sedation, although a skilled examiner can sometimes complete the procedure without sedation. A flexible sigmoidoscopy is similar to a colonoscopy. It uses the same instrument, but the difference is the extent through which the examination is done lang. So it only visualizes a portion of the left colon, usually to 60 cm from the anal verge, and is usually used to evaluate diarrhea and rectal outlet bleeding. Now, we talked about the upper GI tract, the colon, and the longest segment in between the small bowel is actually quite difficult to evaluate in most centers. But there are techniques to evaluate the small bowel via endoscopy, and these three techniques are capsule endoscopy, push enteroscopy, and single or double balloon enteroscopy. Okay, I'll give you a briefing on what these things are. The capsule endoscopy essentially is you have a camera within a disposable capsule, and you swallow it, and as it moves via peristalsis through your small intestine, it produces still images, so pictures, and it transmits these pictures wirelessly to an external receiver. So since it moves throughout the entire length of the small intestine, it is able to visualize the jejunal and ileal mucosa. The downside is that you cannot, it's not a real-time image, and it's not like you can control where you want to see. No? So you are at the mercy of where peristalsis directs your camera. And it's solely a diagnostic procedure. So this is what it looks like. Your CMOS chip is in the capsule, and it transmits images to your receiver, which you're supposed to wear. And images will look like this. You will have a lot of images like this. Now, the downside, of course, is that it's a still image. It's not a real-time image. So if, for example, at the edge of this picture, you say, oh, please move the camera a bit to the left because I want to see something on the left. There seems to be something there. You cannot move it. No? So you are, as I said, you are at the mercy of the images that are provided to you by the camera. Now, some of you might be asking, why not make the upper GI endoscope longer, no? So that it can reach deeper. No? It can reach deeper in. Now, if you were to produce a scope that is as long as your small intestine, then you would have to have a scope that's probably as long as the perimeter of a basketball court. No, now number one, that's not feasible, and number two, it's not just a matter of pushing it along an entire length of intestine. No, an analogy here would be if you have a sock and you want to put it in your arm. If the sock is short, then you can just put your arm in one push while you're pulling on the sock. No, but if the sock is very long, you would have to employ another. You cannot just pull it into your the way females put on their stockings. They don't just put it in and just pull it all the way up to their hip. No, there's a method to pull in a longer piece of clothing on a given length of leg. No, okay. So what we usually use, I'll discuss this. Push enteroscopy is the answer to your first question, using a longer endoscope, similar in design to an upper endoscope. However, If you push it down to the small intestine, you can only reach about the middle of the jejunum. Now remember, there's still another long half of the jejunum plus your ileum pan. So it's an incomplete evaluation because of the technical difficulty of pushing in a scope down a very long length of intestine. So it will look like it looks like your upper GI endoscope, but it's longer. Um, small bowel endoscopy can also be device assisted. The device being balloons, no? So a single or double balloon plus overtube, um, rotating screw-like overtube. So what happens is, this is the example I was giving. If you want to put this sock into your, not a sock, no, into your arm, this length, you can just pull it in. But if it's much, much longer, for those of you who are not familiar with tailoring, no, these are pleats, no. So a longer material is bent into smaller folds so that you can compress them like an accordion, no. So if the sock or stocking is longer, then you can create a lot of folds so that you can compress a longer length of sock across the same length of arm. So that is essentially the concept of balloon assisted enteroscopy, wherein you have your basic scope in black, but you have an over tube, no? So the transparent tube on the outside, no, that's what you see. And the black scope is able to, the inner scope is able to move along the length of the over tube. So what happens is, since the over tube has a balloon, you are able to anchor the over tube at any given point in the intestine, and then you're able to push the inner scope well beyond, no, the over tube, and then you just deflate the balloon, and then you slide the over tube over the scope, and then you go again. The double balloon enteroscope improves upon this design. No, it's similar to the single balloon enteroscope, except that there is also a balloon that anchors the tip of the inner tube. No, so it provides an even better ability to anchor itself, because remember, there's a lot of sliding when you push and pull. No? So you're not only able to anchor the over tube and extend your inner scope well beyond the over tube, but you're also able to anchor the inner tube as your over tube slides over the inner tube. Okay, so you're able to go along a longer length of intestine, and it pleats the intestines like this. Huh? Okay, that this is not a deformity. This is creating a lot of folds to compress your intestine over the tube in an accordion-like fashion. ERCP. This is a procedure wherein you use a side viewing endoscope. Most of the scopes that I had discussed so far have their lens at the tip, at the very tip of the scope. This one has it at the side. Why? Because this is for visualization and access of the ampulla of Vater. So the ampulla of Vater is identified and cannulated with a thin plastic catheter. So the catheter comes out of the side, and you cannulate the ampulla of Vater so that you can inject contrast. Once you inject contrast, you will be able to see your common bile duct and the more proximal biliary system, as well as your pancreatic duct. So you will have actually two images. The upper GI the endoscopy image visualizes the ampulla and allows you to cannulate it. But the image of the common bile duct, the biliary tract, as well as the pancreatic duct, are a fluoroscopic, a radiologic image. So this is why I was saying it is an amalgam of radiography and endoscopy. The sphincter of Oddi can be opened endoscopically, can be cut open endoscopically, and stones can be retrieved from the ducts, biopsies performed, strictures dilated, and stents inserted. This is usually for addressing hepatobiliary disorders. So these are the images that you will see in an ERCP along the fluoroscopic or radiologic side. So here's your common bile duct as well as the intrahepatic ducts. Endoscopic ultrasound, as the name also implies, is an amalgam of endoscopy and ultrasound. It utilizes high-frequency ultrasound transducers that are incorporated into the tip of the endoscope. The ultrasound images obtained of the gut wall, adjacent organs, vessels, and lymph nodes. It's more accurate for pre-op local staging of esophageal, pancreatic, and rectal malignancies. So usually luminal structures. So the tip of you have your transducer at the tip of your scope, and it forms, this is your scope, it forms a radial image of the structures that are around it. Now, NOTES, or natural orifice transluminal endoscopic surgery, as the name also implies, is an amalgam of endoscopy and surgery. It's an emerging collection of endoscopic methods employing passage of an endoscope or its accessories through the wall of the GI tract to perform diagnostic or therapeutic interventions. Examples of this are your percutaneous endoscopic gastrostomy, and I think you've heard a lot of surgery being done already laparoscopically. So this is essentially the concept. This is essentially the concept of inserting a scope. Instead of opening up your patient through a big cut along the abdominal wall, you insert instruments which are extensions of your eyes and hands, and you're able to do your surgery within the uh, abdominal cavity without cutting the patient open. Endoscopic resection and closing techniques include endoscopic mucosal resection and endoscopic submucosal dissection. Okay, they are similar, but I will be showing. These are for resection of benign and early stage malignant gastrointestinal neoplasms. If you would like to avoid cutting your patient open and doing more radical surgery. They provide larger specimens than just the biopsies that you're able to take with the standard upper GI endoscopy or colonoscopy. And they are curative for certain dysplastic lesions and focal intramucosal cancers. So what happens for your EMR, endoscopic mucosal resection, is you inject a substance underneath the mucosa to raise it. And then you loop, you cauterize the area, you cut the area by deploying a loop around it and cutting it off. So I think it will look better in with a real image. So this is your lesion, you want it out, so you inject a substance underneath the mucosa to raise it, and then you cut it, you loop cut it, okay, removing the lesion in question, and you leave this, a shallow crater, which will heal with time. Endoscopic submucosal dissection, is similar in the sense that you want to remove a particular specimen, but in this case, what you do is using a special knife. Okay, you make smaller cuts, and you're essentially cutting around and underneath the structure, and you lift it up, removing it. Okay, so an example here would be, here's your lesion, okay, and you use a special knife to cut around underneath, and essentially you will be able to lift this lesion off, and then you also have this one. Now, you have to know that there are risks for endoscopy, although these are quite small. So what are the risks involved here? Number one, the medications you use for conscious sedation. Okay, in certain patients, the standard side effect for sedatives are respiratory depression or any allergic reactions to any of the medications that you give. Number two, you have to take into account if your patient is on antithrombotic agent use, like aspirin, clopidogrel, and the like. And you have to take into account procedural risk and the patient condition. Now, later on, we'll be talking about, I'll be referring you to the table on antithrombotic use. What are you supposed to do with these agents if your patient is to undergo an endoscopic procedure? Are you allowed to just continue it? Do you discontinue it? When do you discontinue it? Okay, that's all in one table in your textbook. Okay. Infectious complications also are uncommon. However, there are conditions wherein you may need to give prophylactic antibiotics when indicated. Okay, again, there's another table that I can refer you with this to follow. Okay, so here is the management of antithrombotic drugs prior to endoscopic procedures. Okay, so these are the drugs here on the left, and then the bleeding risk. Depending on what the bleeding risk is, what do you do about the drug in question? And if there is discontinuance, then it's very important to know how long the medication should be off before it's safe to do your procedure. Why? Because we're talking about antithrombotic drugs, making your patient prone to bleeding, especially if your procedure needs to include a therapeutic arm. Antibiotic prophylaxis prior to endoscopic procedures here. Okay, these are the patient conditions on your left. Okay, and of course it will depend on not only the patient condition but the procedure being contemplated. Do not worry, I won't ask so many questions from here, but it's important to know uh, it's important to know where you would refer to if your patient is to undergo an endoscopy. You know where to look for the answers, know, and what you should do regarding antibiotic coverage. Overall, if we are talking diagnostic diagnostic endoscopies, the risk is very low. Less than 1 per 1,000 procedures. Risk for diagnostic upper GI endoscopy, colonoscopy, flexible sigmoidoscopy. The risk rises a bit if to 0.5 to 5% if you involve therapeutic procedures. That means if there has to be any cutting, injecting, or cautery involved, or dilatation involved. The ERCP has inherent risks also. There's a risk for pancreatitis and approximately 5%. Remember, you will be injecting a dye into the biliary tree, and connected to the biliary tree is your pancreatic duct. So sometimes this may cause pancreatitis in a small percentage of patients. Higher so if there is sphincter of OD dysfunction in these patients. And if you employ sphincterotomy, that means you cut open the sphincter of OD, then you have a 1% chance of bleeding. The deployment of a gastrostomy tube via PEG, or percutaneous gastrostomy tube, also entails with it a 10 to 15% risk of adverse events, usually infections in relation to the surgical side of the procedure. Now, the most important aspect for all of you, even if you don't become gastroenterologists in the future, the important thing here is that you know what are the indications for doing it. It's also important that you know what risks are involved, but the most important aspect of this chapter is that you know the indications, because even if you are any other subspecialty or specialist, you would know when to refer. So the indications are divided into urgent and elective. Now, this is always a favorite question in examinations. Now, which of the following are considered urgent indications, and which of the following are considered elective? Okay, so let's start with urgent. Number 1, bleeding. Now remember, don't be confused with this. The indication here that is urgent is the state of bleeding, acute gastrointestinal hemorrhage. Now, the lesions you see below, peptic ulcer, varices, Guilfoy's lesions, Mallory-Weiss tears, vascular ectasias, and colonic diverticular bleeds. These are the lesions that may bleed. In and of themselves, they are not urgent indications for endoscopy, but if they bleed, then that makes it an urgent indication. Okay, so the lesions that may bleed, peptic ulcers. I won't stay too long here because we have an entire chapter to follow. Suffice it to say, that's what you know what an ulcer looks like. Just imagine bleeding coming from it. The bleeding can be in a spurting fashion. It can be in an oozing fashion. Okay. Varices. We will also have a separate chapter on the complications of cirrhosis and portal hypertension. So we'll be discussing the management there. But suffice it to say, you can have varices and you can bleed profusely through these varices. Now, remember, a varix, an esophageal varix, and even a gastric varix is a high pressure vessel. It is caused by portal hypertension, And therefore, if it pops, or if you get a rent in any across the intact lining of that varix, the bleeding can be profuse and very life-threatening. A Julophoist lesion is a large caliber artery that runs beneath the mucosa and bleeds through a pinpoint mucosal erosion. So you will see the vessel, but you won't see it runs underneath the mucosa. You will just have a pinpoint break through which you can have the bleeding. A Mallory-Weiss tear is a linear mucosal rent or a break near or across the gastroesophageal junction related to retching or vomiting. So you will see a lot of these in patients, like patients or heavy drinkers. So during their alcohol sessions, they're drinking binges. They exit the bar, or they exit wherever they're having their sessions, and then they vomit a lot. You will see a lot of these Mallory-Weiss tears. It will look like such. It's just essentially a tear at the GE junction in a patient with a history of vomiting, profuse vomiting. Vascular ectasias are flat mucosal vascular anomalies, usually causing slow intestinal blood loss, either sporadically or in well-defined patterns of distribution. If the distribution is wide, we also call this sometimes a watermelon stomach. Mucosal vascular anomalies, and then look at the pattern distribution. If you look at it, we call this a watermelon stomach. And colonic diverticular, which are outpouchings of your wall, your colonic wall, in areas of weakness. Now, from the inside, you will see pockets. Another urgent indication, apart from bleeding, is gastrointestinal obstruction. So if you have an acute esophageal obstruction, gastric outlet obstruction, or colonic obstruction. Now, take note, in complete colonic obstruction, this actually is a contraindication to performing a colonoscopy, because you will not be able to prep your patient. You won't be able to give your laxatives and fluids to wash out the colon because it's obstructed. So it will actually cause more abdominal distension. Or if you do the procedure and you put in gas, the patient won't be able to pass it out. Your patient will have abdominal distension. For acute esophageal obstruction, usually this is from impacted food or anything that might be swallowed in. If it's child, then of course it's not just food, but practically anything that they can put in their mouth. Or it can be ingested foreign body, even in adults. So an upper GI endoscopy is necessary here. Okay, so examples of foreign bodies, food. Okay, it says hot dog. It doesn't look like a hot dog, but just take their word for it. Or any food for that matter. And the one below, like I said, any foreign body that's not food and should not be there is considered a foreign body. So gastric outlet obstruction, for example, in the case of gastric, duodenal, pancreatic malignancies that are pressing on the pathway. Chronic peptic ulceration causing stenosis of the pylorus. Okay. Upper GI endoscopy is indicated to diagnose that. So this is an example of stenosis. In some cases, you can insert a deflated balloon and inflate it to essentially stretch open the opening. You're essentially kind of cracking it open, stretching it open, tearing it open. And then, of course, for colonic obstruction, we're talking about partial obstructions, colonoscopy. Like in the instance, obstructions due to tumor. Another urgent indication is acute biliary obstruction. Okay, and usually we do ERCP for this one, for bile duct imaging, ascending cholangitis, and gallstone pancreatitis. ERCP is employed here because you have direct access into the biliary tree. Plus, you have therapeutic value for your ERCP. You can do sphincterotomy, insertion of stents, removal of stones. Now, elective indications, so that means there is time. There is time for you to schedule, time for you to prepare. You don't have to do it within a 24-hour period because it's an emergency. So elective indications include dyspepsia, that means symptomatic patients from dyspepsia, GERD, gastroesophageal reflux disease, peptic ulcers, or non-ulcer dyspepsia. Now remember, peptic ulcer was also in under urgent indications, but I would like to again remind that the indication for the urgent indication is when the lesion bleeds, whatever it is. If it's bleeding, it becomes an urgent indication. Otherwise, the presence of the lesion per se makes it an elective indication only. So dysphagia, the scheduling for an EMR, ESD, as I described, anemia evaluation for patients with occult blood in the stool, colorectal cancer screening for those who are 45 and above or have a corresponding family history of CA, diarrhea, minor hematochezia, pancreatitis, and cancer staging. Now remember, usually we can get 1 or 2 questions out of indications alone. Okay. I would also like you to take a look at and be familiar with colorectal cancer screening strategies. Whether it's from the ACG, American College of Gastroenterology, or other bodies, because even if you turn out to be an obstetrician or a pediatrician or any other specialty for that matter, it is always good to be able to advise your patients when they should have their initial screening and subsequent surveillance for all types of cancers. Like, you should be able to tell your patient when they should have their mammogram for breast cancer screening and surveillance, their pap smear. For males, when should they be having their evaluation for their prostate? For patients with corresponding family histories, when should they be having their ultrasound to check their liver, their pancreas, and most importantly, colon cancer screening. The March is colon cancer screening month. And even esophageal and gastric cancer. You should know when these things need to be done initially based on the patient's family history. Even if they are average risk, there's a screening recommendation for that. So you should know when you should start evaluating patients and how often you need to evaluate these patients and what tests you can employ. So number 1, the categorizations are average risk patients. That means you're run-of-the-mill patient, no family history, no personal history. By the way, this 50 years of age has already been lowered because of findings that patients with colon C are getting younger and younger. So this has been reduced to 45. Average risk patients with certain conditions like inflammatory bowel disease, okay, especially if it has been going on for years. Patients with a personal history of certain types, number, and size of polyps, or patients with a personal history of colorectal cancer, as well as patients with a family history of polyps or colorectal cancer. So again, I mentioned this, we showed this earlier regarding the, just be familiar with the management of antithrombotic agents for endoscopic procedures. What are commonly used in our setting? Aspirin for patients with cardiovascular risk factors, patients who are also using thienopyridines, like clopidogrel, warfarin. Okay, how to proceed when of low or high risk bleeding? Do we continue, discontinue? And if you discontinue, how long should the medication be discontinued before it's safe to perform your procedure? Okay. Again, this is a table in your text. You don't have to memorize everything here, but as you are thrown into the field na niya, the basics here are aspirin, clopidogrel, and warfarin. But as you are thrown into the field, you will realize that there are more medications out there. You have apixaban, you have rivaroxaban, dabigatran. You have all these medications here that cardiologists use, so it would be best to be familiar at least with how to deal with them if your patient needs to undergo diagnostic workup for GI-related problems. Okay, so for upper GI endoscopy, these are things that you will usually see when you're going in. So you will pass by the normal vocal cords as seen prior to entering the esophagus. Now, of course, we don't enter that because that leads to the airway. Our area of concern is the food tube, the alimentary canal. So the esophagus is a smooth tube pinkish in color, and then you will know that you are hitting the junction between the esophagus and the stomach because it will turn out to be a more reddish color. So apparently esophagus is Lenny and stomach is BBM. As you enter the stomach, no, I think you are familiar with this from your basic anatomy. Um, the rugae of the main body of your stomach, and this smoothens out into the antrum. And when you hit the end of the antrum, you have an opening, the pyloric opening, which leads to your duodenum. And this is you will know that you're in the second portion of the duodenum because you will see your ampulla. Now, if you take a look at this, it will be very difficult to cannulate this because you are using a front viewing scope. That means the lens is at the tip. And that is why an ERCP uses a side viewing instrument. The lens is at the side, so that all you'll have to do is pass the scope and align the lens with the ampulla, and it will be easier to deploy your cannula for cannulation. Okay, here are some abnormal things that you might see, no? So esophageal webs and rings, no? So these are smooth, circumferential, either rings of squamous mucosa, often responsible for difficulty in swallowing, which can be located anywhere along the esophagus, or maybe asymptomatic if it's not causing enough of an obstruction, okay? So this is the ring, this is the web, no? Okay, I'll make this clear, no? Now, this is supposed to be the actual lumen of your esophagus. This is the extra mucosa, okay? This is the web, no? It's not supposed to be there because your lumen is supposed to be this entire thing here, no? So you have partial covering. So you can understand why, depending on how bad the web is, no, or how much is covered, or if it's circumferential, if it's a ring, it will cause obstruction, no? So in this case, this is the actual esophageal lumen. This is supposed to be the what do you call this, the circumference of your esophagus. But now it has been reduced to this to this diameter, sorry, this circumference, because of all this mucosal tissue that is causing partial obstruction. Okay, this is an esophageal diverticulum. No, from the outside, it will be, from the outside, you will see it as a pocket. But from the inside, you will see it as a outpouching. But from the inside, you will see it as a pocket. No? So in fact, if you're looking here, you will be hard pressed to tell which one is the actual lumen here, except that in this particular picture, you see light reflecting at the end. No? So this is the pocket. This is the outpouching. This is your actual esophageal lumen. Mallory Weister, I think I discussed this earlier. No, it's a rent or a tear caused by the force of vomiting, usually at or just below the esophagogastro junction. No, foreign bodies, it can be food or it can be non-edible materials in either very old patients, very young patients. Reflux esophagitis. Okay, so this is mucosal inflammation caused by the reflux of irritant material, usually gastric acid, into the esophagus. With increasing severity, this may be associated with erosions, ulcerations, and even strictures. Infectious etiologies of esophagitis are also possible. In this case, fungal, and in this particular case, candida, wherein you have whitish macules, which may develop later on to more severe inflammation and ulceration. Esophageal varices. No, for those of you who have clear veins on the back of their hands, no, it actually looks like that if zoomed in. No, so you will see varices in the mid to distal esophagus, depending, of course, on the severity of the increase in portal pressure in patients with portal hypertension. Here and here, and remember, I mentioned that this is an area of very high pressure. So if there's a break along the lining of this, then you can have very profuse bleeding. Now, this I'll be discussing more on this when we come to portal hypertension, but essentially what I'd like to explain is, aside from the diagnostic value of doing an upper GI endoscopy, you have therapeutic value in it, so you can band these esophageal varices, using these small rubber bands. And of course, the most dreaded lesion along any of these segments of your upper GI tract or even the lower GI tract is cancer. Gastritis, you have the same spectrum. You can have inflammation, gastritis. You can have ulceration. Another example of ulceration, those were benign ulcerations, but and complicated ulcerations wherein you can have bleeding. This is a healing ulcer with scar tissue around. And you can also have ulcerations with irregular margins around that can be malignant, like such. For your small intestine, it's the same spectrum also. You can have inflammation, duodenitis. You can have ulcerations in your duodenum. And you can have polyps and also, there should be another slide here after. You can also have malignancy, although malignancy is not as common in the duodenum as it is in the stomach. So more findings, this time in the lower GI tract, in the colon. You can see strictures, pockets or outpouchings of the colonic wall. We talked about this, diverticulosis. You can have vascular lesions, the form of angiodysplasia. You can have polyps, and of course, you can have malignancy. Okay, before I, sakto good, 1 hour, almost exactly 1 hour. Before I shift to the next topic, are there any questions?
And so far, Doc.
Okay, so let's. You want a pee break, or do we just go ahead? Just proceed, okay? Anyway, if you do pee, I won't be able to tell. Okay, our next topic for this morning is on the medical management of peptic ulcer disease and related disorders. Now, of course, we touched a bit on this when we were talking about the physical appearance of the stomach. No? So you start off with your rugae in the more proximal, especially in the more proximal aspects of the stomach. Now, if you zoom in, then you will find that your rugae are made out of gastric glands, and each of these gastric glands further branches out, gastric pits, which branch out into gastric glands. Now, if you look at these gastric glands, the area of interest here is this one. Depending on where you are along the stomach, these glands may differ in terms of cell components. So glands within the cardia, that means the area just beyond the esophageal attachment to your stomach, usually contain mucus and endocrine cells. Glands in the pyloric glands in the antrum contain mucus and endocrine cells, usually your gastrin cells. Your G cells, we'll talk about that later once we talk about stimuli to acid secretion. And then glands within the oxyntic mucosa, usually we're talking about those in the body, contain mucus, parietal, chief, endocrine, and ECL, enterochromaffin-like cells. Now, our cell of interest for the purposes of this discussion is the parietal cell. It's also known as the oxyntic cell, and is usually located in the neck or isthmus of the oxyntic gland. Okay. This one. Now, the thing you have to understand is that at resting, in its resting state, it has prominent tubulobesicles and intracellular canaliculi. Okay, so just think, tubulobesicles, canaliculi, containing short microvilli along the apical surface. Okay, short microvilli along the apex of the cell. short microvilli along the apical portion of the cell itself. However, you will see the difference when it is stimulated. So stimulation, when you stimulate the parietal cell, the proton pump, or what we call hydrogen potassium ATPase, is expressed in the tubulovesical membrane. Okay, let me show you here. No, it's expressed in the membrane here. We call this the proton pump. This membrane, as well as the apical membrane, transforms into a network of apical intracellular canaliculi containing long microvilli. So the previous microvilli that you saw prior here in the resting state elongates, no? And along the surface here, this is where your acid secretion takes place. Now, it's very important for you to understand the normal physiology of acid secretion in terms of what things stimulate acid secretion and what things inhibit acid secretion. Why is this important? Not just for the sake of memorization, because later on when we talk about okay, here are the hints, no? Okay, so the items of importance here are, number one, vagal stimulation. Okay, so that means we are talking about nerve stimulation, vagal stimulation. That means what is the direct stimulant? Acetylcholine. Okay, acetylcholine, number one. Number two, gastrin from the G cells. Number three, histamine. Number four, somatostatin from your D cells. Okay. Now, the reason why it's very important for you to understand this basic concept is that later on, if I will be talking about, oh, the patient needs to undergo surgery, the surgeon did a vagotomy cut. So you will understand why the vagotomy needs to be done, because you want to reduce acid secretion, because the vagus nerve, the acetylcholine that comes from the vagus nerve, stimulates acid secretion. Okay, so acetylcholine stimulates, histamine stimulates. That's why one of the drugs later on we will be talking about are histamine receptor blockers. No, so histamine stimulates acid secretion, gastrin stimulates acid secretion, and the last is somatostatin, which inhibits acid secretion. Okay, so of the four, just try to remember it simply lang. Basta somatostatin is the one that is the only one that that inhibits acid secretion. The rest are stimulants. Okay. Even the inhibitory nature of somatostatin will be important later on. You might not realize it now, but later on, when you are giving somatostatin for some other reason, in this case, when your patient has portal hypertension and is bleeding from esophageal varices, you will give somatostatin. No, and then your consultant might ask you, if you are the resident, the consultant will ask, okay, shall we give an additional proton pump inhibitor or not to suppress acid? Then you can always say, you know, doc, somatostatin already inhibits acid secretion. You know, that very statement will elevate you to will elevate you to top 10 status na dayon right then and there, will impress your consultant. No, so these are pearls that are very important. But for your purposes now, just remember those: acetylcholine, gastrin, histamine, stimulants, somatostatin, inhibitor. Okay. Ironically, the one with the S is the one that is not a stimulant. Okay. So just remember that this has come out in the exam for the past 10 years. So it's not exactly leakage, but a very helpful tip for you. Okay. Now, in terms of acid secretion, okay, so remember those four. Okay, so basal acid output. Okay, that means unstimulated pa na siya. There's no food involved. There's no nothing. It's basal acid output. Is contributed to by cholinergic input. That means vagal input and histaminergic input. Okay, so histamine and acetylcholine are contributors to basal acid output. Now, stimulated acid output. That means that this has three phases. No? Cephalic, gastric, and intestinal. So I think most of you know this from basic physiology. No? So stimulated acid output, just the sight, smell, taste of food. No? Some even suggest even the thought of food already stimulates acid secretion via cholinergic input. Okay, so there's no actual physical substance in your stomach, so it does not stimulate gastrin, it does not stimulate somatostatin or anything. No, so it's mainly cholinergic input. No, so for the cephalic phase. Now, for stimulated acid output, gastric phase. Now, this is determined by physical entry of food into the stomach. No? So whatever is physically present to distend your stomach. So what is in the stomach? Your G cells, stimulating gastrin release, which is a stimulant or inhibitory. So a stimulant. No, gastrin is a stimulant. So okay, now acid output, intestinal phase. Okay, which is the opposite. This is initiated as food physically enters the intestine. No, so again mediated by distension of the intestines. No, so here what is what is released is somatostatin from your D cells, and we talked about somatostatin as the only one of the four that is an inhibitor of acid secretion. Okay, so it has direct effects on the parietal cell, inhibition, and indirect effects, which are decreased histamine release from the ECL cells, ghrelin release from ghrelin cells, and gastrin release from G cells. So at least of the four, you know which ones are in operation during basal acid output and during the different phases of acid secretion. No? So cephalic, gastric, and intestinal. Now, it's a wonder that with all these aggressive factors to which the upper GI tract lining is exposed to, so acid, pepsin, bile acids, pancreatic enzymes, drugs, bacteria, and other things that we may be ingesting, which we call aggressive factors, it's a wonder that not everybody has an ulcer, no? And this is because that you also have balanced it. You have a balance between these aggressive factors and what we call the protective factors. Now, these protective factors of mucosal defense are in a three-level barrier: pre-epithelial, the epithelial line, and the subepithelial line. The first line defense is the mucus bicarbonate phospholipid barrier. So you have a line of mucus and bicarbonate, so that the first contact pa lang of your aggressive factor, especially your acid, already encounters a neutralizer in the bicarbonate. Number two, you have a physicochemical barrier to multiple molecules. The second line defense are the actual tight junctions between your surface epithelial cells. No? And you have at that level mucus production, maintenance of an intracellular pH, bicarbonate production, and intracellular tight junctions. The third line defense is below. So the microcirculation, which provides bicarbonate, an adequate supply of micronutrients and oxygen, and the removal of metabolic byproducts, as well as prostaglandins, which maintain and enhance all mucosal defense mechanisms working synergistically with nitric oxide. It's very important to remember how important prostaglandins are in the protective mechanism side of the seesaw, between aggressive factors and protective factors. Now, as you remember, where do you get your prostaglandins? Now, esterified arachidonic acid is acted up, which in itself comes from membrane phospholipids, acted upon by your phospholipids A2. No, your arachidonic acid is acted on by two isoforms of your COX enzyme, COX-1 and COX-2. For our purposes here, the important COX isoform is the COX-1, which is these forms of prostaglandins are very important in maintaining gastrointestinal mucosal integrity. We will still, however, be touching on the COX-2 isoform later on, especially once we're talking about management, because pathophysiology and management, because the COX-2 enzyme is a mediator of inflammation. So in this event, it's actually not directly involved here, but later on we will be discussing, once we touch on pathophysiology of ulcers and management of ulcers, we'll be talking about where the role of COX-2, the COX-2 enzyme lies. No, but for present, no, this is the important COX isoenzyme. And therefore, if you have a balance, no, I call this the seesaw. No, so if you have a balance between the aggressive factors and protective factors, there should be no ulcers. And this explains why not everybody has ulcers despite the exposure to all these aggressive factors. It is only when you have an imbalance in the seesaw between the aggressive and protective factors, either reduction of protective factors or significant increase in aggressive factors, that you have mucosal injury and that you may have a defect in the mucosal lining. Depending on how deep, it may be erosions. If it's deep enough, then you call it an ulcer. So therefore, what is an ulcer? An ulcer is a disruption of the mucosal integrity of the stomach and of the duodenum, leading to a local defect or excavation due to active inflammation. In short, if this were a big piece of land, you'd call it a crater. Now, the usual causes for the most common causes for peptic ulcer disease, number one, Campylobacter or Helicobacter pylori infection, and number two, non-steroidal anti-inflammatory drug use. And now you begin to see the beginnings of why we were talking about prostaglandins in the first place. No, but there are also other causes for peptic ulcer disease and ulcerations along the upper GI tract. No? Infections in immunocompromised patients, especially your cytomegalovirus, herpes simplex virus, no? Drugs and toxins. No? Patients who are or are on biphosphonates, chemotherapy, clopidogrel, steroids, under the right conditions, and miscellaneous causes, including ischemia, Crohn's disease, eosinophilic infiltration, radiation therapy, and infiltrating disease. Now, we will be touching on this particular concept a few more times heading forward. That NSAID-induced disease is based on two aspects: the interruption of prostaglandin synthesis. We were talking about this one, the what do you call this? The COX isoenzyme, inhibition of the COX enzyme, and the topical effect of your NSAIDs and aspirin. So this will be a recurring question later on. What are your comments regarding the argument that a patient can just use an enteric-coated tablet when using aspirin, for example, and that would make the condition fine? I'll come back to that later in a few slides down. Okay, so I mentioned that there, number one, you have a systemic effect, because when you have your supposedly you're supposed to produce what do you call this, prostaglandins that are meant for housekeeping purposes. That's mediated by your COX-1 isoenzyme. So these are the prostaglandins that are supposed to maintain gastrointestinal mucosal integrity. So if something happens to that because of medications you're taking, i.e. NSAIDs, so you tip the balance in favor of the aggressive factors, and therefore you may get defects in your mucosal upper GI tract lining. Now, as to the pathology of ulcers, here this is where we deviate between GUs, gastric ulcers, versus DUs, duodenal ulcers. Now, gastric ulcers can represent malignancy. Benign ulcers are often found distal to the junction between the antrum and the acid secretory mucosa. That means the body of the stomach. Histologically similar to DUs. Okay, so where is your oxyntic mucosa? Your oxyntic mucosa is along here, along the main body. So if you draw a line here, all ulcers that are located in the distal stomach, that means in the antrum, are usually benign. Usually, it's not a perfect science, but usually they are benign because they, as I will be showing later, they usually act like duodenal ulcers here, which are also usually benign. Now, benign gastric ulcers associated with there's a distinction between benign gastric ulcers that are caused by Helicobacter pylori and benign gastric ulcers that are associated with the use of non-steroidal anti-inflammatory drugs. Now, those ulcers that are associated with Helicobacter pylori are associated with antral gastritis. So Helicobacter pylori infection also has inflammation. Gastric ulcers that are associated with NSAIDs are not accompanied by chronic active gastritis. So those that are caused by NSAIDs are not accompanied by inflammation. So how do I explain that? Now remember, if you're using an NSAID, most of your NSAIDs are non-selective. That means they will block both COX-1 and COX-2. If you're having a hard time remembering, because it comes out in the exam, which of the two gastric ulcer types categories are associated with inflammation? A, Helicobacter pylori infection. B, NSAID, NSAID use causing the ulcer. Now remember, think of it this way. Helicobacter pylori is an infectious agent. So therefore, when you infect your mucosa, you are bound to have an inflammatory response by your body. As opposed to if you are using NSAIDs. Now remember, the NSAIDs will block both isoforms, COX-1 and COX-2. So you have the ulceration because you have reduced the gastrointestinal mucosal integrity by virtue of blocking COX-1. But remember, it also blocks COX-2. But COX-2 is a mediator of inflammation. So you're actually giving something that is an anti-inflammatory. So it's actually the opposite, no? So it doesn't. We're not saying that NSAIDs are not associated with inflammation precisely because your NSAID is an anti-inflammatory agent just by name itself, no? So if you want to try remembering which one of these two gani, okay, just remember the infectious agent is the one that is associated with inflammation by virtue of the body response. But the NSAID, no inflammation because precisely it's an anti-inflammatory agent for examination purposes. Okay? Duodenal ulcers most often are in the first portion of the duodenum. 90% occur within 3 cm of the pylorus. Malignant DUs are not impossible, but they are rare. Okay, so you will have it. This is the bulb, first portion. No? You will have it usually here in terms of location, and most of them are benign. We'll also be explaining later, I mentioned this earlier, that the ulcers that are found in the distal stomach are usually benign and behave the same as duodenal ulcers. And we will see why. Okay, and that's because of the difference in the pathophysiology between duodenal ulcers and gastric ulcers. Okay, now patients will often come to see you, diba? And when they have epigastric pain, burning epigastric pain, they will usually say, "Doc, I have burning epigastric pain." They will either say, "Doc, maybe I have an ulcer," or "maybe I have hyperacidity." That's what those are the terms that they usually say. So they have a notion that an ulcer is associated with increased acid secretion, but that is not true in all cases. Okay, so you will have to know when hypersecretion of acid happens. No, when is basal and nocturnal or stimulated acid secretion increased? Is it with duodenal ulcers or is it with gastric ulcers? The general tendency for medical students, Manggod, is to think this way: where is acid secretion high, duodenal ulcer or gastric ulcer? Well, there's a lot of acid in the stomach, so it must be in the stomach because there's a lot of it. Well, actually, the answer is the logical thinking is wrong. No, remember the natural state of the duodenum is that it's not an acidic environment, so it is not used to acidity, to a low pH. It's not used to high levels of acid. It's not used to a low pH. It's not an acidic environment. And therefore, if you increase the acidity in the duodenum, what happens? You tip the balance of the seesaw in favor of aggressive factors. Therefore, you will be able to generate an ulcer. Okay? So the average basal and nocturnal gastric acid secretion in duodenal ulcers is increased. Think of it that way. Okay? Do not think of the stomach. The stomach has a lot of acid, therefore it has hyper. The stomach already has a lot of acid. The stomach pH is already very low. The stomach acidity level is already very high. So that's not it's not hyperacidity. It's already supposed to be high, okay? But in the duodenum, it's not used to high levels of acid nor to low pH. Okay? Bicarbonate secretion is decreased in DU patients, and H. pylori may play a role in the above processes. Now, this is what I mentioned. Basal and stimulated acid output in gastric ulcers is normal to decreased usually, with one exception, and I will be showing that later. Okay, but we will be talking generalities unless I specify. Okay, so if you are asked in examination, where will you expect high acid output, whether basal or stimulated basal or nocturnal? Is it a DU or a GU? Then your answer should be a DU. Okay, because normally in a normal duodenum, you do not have hyperacidity, you do not have low pH, you do not have high acid output in the duodenum. Okay. In the GU, in the gastric area, for gastric ulcers, basal and stimulated acid output is actually normal to decreased. Okay, because the pathophysiology for gastric ulcers is more of an impairment of the mucosal defense factors. That means in the seesaw that I mentioned again, the protective mechanisms became lighter. So pildi sila. Pre-pyloric ulcers, okay, so that means antral ulcers and ulcers close to the pyloric opening, or body ulcers associated with the DU scar are similar in pathogenesis to DUs. Okay, so based on location of gastric ulcers, there is a variation in acid production. Now, if you look type 1, 2, 3, and 4, there's only one exception, and that's type 3. Those ulcers that occur within 3 cm of the pylorus, they may have normal or high gastric acid production. But for the grand majority of gastric ulcers, this is what we mentioned, acid production will be either low to normal. Okay, so unless I specify in a type 3 ulcer, what is the expected acid output? Okay, unless it's specified that way, the generality is still duodenal ulcers are associated pathophysiologically with high acid output, and gastric ulcers usually low to normal. Okay. Helicobacter pylori, okay, the number one cause of peptic ulcer disease, no, the most studied, no. Infection of the above microorganism accounts for the majority of peptic ulcer disease. It also plays a role in other disease entities, MALT, mucosa-associated lymphoid tissue, and gastric adenocarcinoma. Helicobacter pylori is an S-shaped multiple sheath flagella with a multiple sheath flagella. It's a gram-negative microelephylic rod. Looks like this. No? Okay. It's most commonly resides in the deeper portions of the mucous gel coating the gastric mucosa or between the mucosal layer and gastric epithelium. It initially resides in the antrum, but over time migrates proximally, especially in those patients who are taking acid suppressants. Factors that predispose to higher colonization rates. Now, if you will notice, all of them pertain to the luoy. No? So the poorer, the dirtier, the unsanitary, the unhygienic. No? If you look at it, factors that predispose to higher colonization rates: poor socioeconomic status, less education. Others, crowding, residents in a developing country, unsanitary living conditions, unclean food, water, exposure to infected gastric contents. No, so take a hint. If an examiner inserts which of the following is a risk factor for Helicobacter pylori colonization, and then they start putting nice things, no, that cannot be the answer. Look for the one that's poor, dirty, unhygienic. Okay. The effect of Helicobacter pylori on the GI tract is variable and determined by microbial and host factors, and the type and distribution of gastritis correlates with the ultimate gastric and duodenal pathology that follows. So for those who have antral predominant gastritis, these patients usually develop duodenal ulcers, and for those who develop corpus or body predominant gastritis, these are the patients who usually develop gastric ulcer or cancer. Now, for NSAID-induced disease, no, for patients who are taking pain relievers, no, so all these things on TV, Alaxan, no, Alaxan, Gardan, the mefenamic acids, the profens, the ibuprofens, ketoprofens, established risk factors for the development of NSAID-induced disease. At number 1, advanced age, history of ulcer, concomitant use of steroids, high dose and or multiple NSAID use, the concomitant use of anticoagulants and clopidogrel, and serious multisystem disease. Now, all of these are understandable. So it would be difficult if I ask you to tabulate it. No, so okay, I give you a sheet of blank paper and then give me established risk factors and said induced disease. I would understand if you miss most of this. But if these are presented in a multiple choice format, which of the following are established risk factors? Established meaning we're sure, because the next would be possible risk factors lang. No, but if you look at established risk factors and you see this list, you should be able to tell na, yes, that's an established risk factor. Yes, that's an established risk factor. Okay. Possible risk factors include concomitant Helicobacter pylori infection, cigarette smoking, and alcohol consumption. Be careful about this because usually we attribute alcohol and cigarette smoking to a whole gamut of medical conditions. So we're not saying that they are not involved. They're just possible risk factors. They're still under study. These are the tests for detection of Helicobacter pylori. We have invasive tests. That means you have to get a sample during your endoscopy or you have to have a biopsy required. So your rapid urease test, histology, and culture. We have, however, non-invasive tests that are quite good in terms of sensitivity and specificity. Blood-based tests, your urea breath test, and your stool antigen test. No, the sensitivity and specificity are still quite good. So it does not mean that every time you need to check for Helicobacter pylori, you need to do an endoscopy each time. No. You might have your initial endoscopy done and an invasive test was done. Usually we use the rapid urease test. And then on follow-ups, you can use a non-invasive test after your patient has been treated. Okay, so for NSAID-induced disease, okay, we talked about this earlier. It involves the interruption of prostaglandin synthesis and impairs mucosal defense and repair. Facilitating mucosal injury by systemic mechanism. And it also involves topical contact of the irritant tablet or capsule, no? Which increases epithelial surface permeability. And it can also alter the surface mucous layer. So we have a topical mechanism. So and therefore, no, was thinking about a bonus. Is there any one of you who can tell me, no, regarding that question I had earlier, no? This will come out in the exam, usually, in the form of a case. So a 60-year-old male with cardiovascular risk factors, he's hypertensive, diabetic, has dyslipidemia, has been advised the use of aspirin, which he took for quite some time. Later on, he had epigastric pain and had an episode of bleeding. And an upper GI endoscopy revealed that this patient has a gastric ulcer in the antrum, as well as an ulcer in the duodenum. Or let's just say gastric ulcer lang. Let's not make it too bad. No. You advise the patient not to continue the aspirin. However, or to mitigate the irritant effects of the aspirin, or to find some way around the irritant effects of the aspirin, which we can provide. However, the cardiologist was adamant, no, you just continue the aspirin because the aspirin I am giving you is enteric coated. No? So for those of you, I think most of you should be familiar at this point in your careers on what an enteric coated tab is. No? So question, does the provision of an enteric coated tablet of aspirin prevent further formation of an ulcer in this patient? If anyone can answer voluntarily, then I'll automatically put that question in the exam. So nanamoy 1 point, and you'll know the answer already. So -1. I'll give you 20. I'll give you 20 seconds to think about it, and then if somebody wants to volunteer to answer, no, this is just conversational. There's no no stress on your part. No fun. It's something just to discuss and to just make sure that you're still awake.
What is the question?
The question is, your patient is on aspirin, 60-year-old patient on aspirin, epigastric pain, bleeding, upper GI endoscopy was done, the finding is an ulcer in the stomach. Let's just say benign ulcer in the stomach. You advise to stop the aspirin because it's obviously a cause for the ulcer. But the cardiologist who administered the aspirin said that, oh no, you just continue because the tablet is enteric coated. The aspirin is an enteric coated tablet. That's what I'm giving you. So it's safe to use. It won't harm you. It won't harm your stomach lining. So the question is that enough of a measure to prevent another ulcer from happening?
I think depends on the dosage stock of your enteric coated aspirin.
Uh, Pardon,
But
what were you saying?
depends on the dosage. Siguro you can ask for the dosage
No,
that was given.
standard dose. You're using the
Standard
lowest
dose.
possible dose. You're using the aspilep. You're using the aspilep, which is essentially 80 milligrams. 80 milligrams per day.
Doc, may I try to answer?
Yes,
Question?
we're just talking.
Uh,
Go ahead.
if from my understanding, Doc, I think the entire coated tablet just slows the release of the drug. So
Yes.
this would delay the pain, but that not necessarily it will delay the production of an ulcer, if I'm not mistaken. So the ulcer will still factor, but then it will just take longer to
The nature of, okay, let me clarify that the enteric coated tab is constructed in such a way as that so that you will not release everything very early in its trip ba in your upper GI tract, no? So most tablets will be released dayon sa stomach, di ba? Most tablets when you, or capsules, when you break them down, they will be released in the stomach. But an enteric coated tab is a bit more hardy, no? So it's not easy to break it down, so it will reach further down. So in that regard, sakto ka nga, you're right nga, it reaches further down, so it bypasses the earlier parts of the upper GI tract. So probably most of the stomach will not be hit directly because the breakdown is delayed. So it goes further down. So you're partially right, but the main question was, will that be enough to prevent an ulcer from happening again? The answer
No,
is
Doc.
actually in front of you
Right.
on the screen.
Uh, Doc, for enteric coated tablets, Doc, so they can address like the topical irritant factor of
Yes.
NSAIDs, but
Yes.
since they do break down in the in the more basic pH of the intestine, so they can still exert like they can still alter the GI mucosal integrity, so
Yes.
they can still decrease the production of protective prostaglandins. So if like so yeah they the stomach can if the stomach produces the constant amount of acid, they have lesser protective
Yes. That's
barrier.
right. That's right. No, so your answers are logical and especially your answer is correct. I don't know. So as you can see, there are two mechanisms by which NSAIDs produce injury to the mucosal lining. No, so the systemic and the topical. So your enteric coated tab addresses the topical because at least your stomach lining will be spared the trauma of being irritated by the physical contact of the medication of the tablet. However, even if it goes down deeper, it will still be absorbed and it will still act the same way. No? So it still has a systemic mechanism. So as you said, it will still act on your COX isoenzyme. So it will still affect the housekeeping ability of your COX-1 enzyme. So it will it will still tilt the CISO in favor of aggressive mechanisms because you will have reduced prostaglandins and you will have reduced protective prostaglandins, and therefore you will have reduced mucosal protective mechanisms. So you will still get the injury, and that is why um, the current recommendation for patients who really need to be on NSAIDs or aspirin, and I'll have a table for that for you later on, no, is you, instead of removing it because you can't remove it, or like it's the same as a patient who is on an NSAID must have the NSAID because the patient is in severe pain. You cannot pull it out You cannot pull it. You cannot remove it because the patient is in severe pain. What will you do? You usually add something. Okay, and that's what we'll talk about later when we come to management. Okay, but correct answers. Okay, so that's one question I've read. I'll probably rephrase it a bit, but essentially you know what the question is about. Okay, the clinical presentation. Usually these patients, classically, we know that these patients will manifest with abdominal pain, although it's possible for a patient to have an ulcer but feel nothing. No, but we're talking about classic presentation. So the patient will usually have epigastric pain in this spectrum: burning, gnawing, aching, hunger pain, hunger pangs. No? Typically, duodenal ulcer occurs 90 minutes to 3 hours after a meal. Why? Because usually usually your food stays permanent in the stomach for a few hours. No? It's relieved by antacids or food, and it may awaken the patient from sleep between the 12 to 3 a.m. period. No? But this occurs in 2/3 of duodenal ulcer patients, but it's not solely belonging to the realm of DU. It may also be seen in 1/3 of patients who have no lesions at all, and these are non-ulcer dyspepsia patients. Typically for GU, pain may be precipitated by food, and depending, of course, on the impact on appetite and nausea and vomiting, um, these may be more common compared with duodenal ulcer cases. The physical examination may be more important for discovering complications rather than for helping you diagnose an ulcer. No? The most frequent finding will be epigastric tenderness, which is found just right of the midline in 20%, but it has low predictive value in telling you whether this is an ulcer or not. In fact, you won't be able to tell the difference between an ulcer and gastritis purely by physical examination findings and history. You won't be able to tell the difference between an ulcer and a patient who has non-ulcer dyspepsia or functional dyspepsia. That means no lesions but has symptoms similar to those of other acid peptic disorders. No? Which is why an upper GI endoscopy is sometimes needed to differentiate one from the other. Complications: bleeding, perforation, and gastric outlet obstruction. Okay. This is understandable. If the ulcer gets deep enough and reaches the submucosal layers, then you'll hit blood vessels, and of course, you'll have bleeding. Now, bleeding is the most common complication because as the ulcer gets deeper, the first that you will hit will be the blood vessels. It occurs in 15% of patients and is more often seen in patients who are age above 60. 20% may bleed without any preceding warning signs or symptoms. It's not like especially older patients, they just come to the emergency room because they're bleeding. And then you pick up from the history that they've been on NSAIDs for a long period of time, or they've been on aspirin or clopidogrel for long periods of time. But when you ask them, they haven't necessarily been complaining of epigastric pain intermittently for a long period of time. Now, if the lesion gets deeper, deeper, and deeper still, no, then of course you'll pass through the entire layer of the stomach wall, entire thickness of the stomach wall, and you'll get a perforation. So that's the second complication that might happen. And then number 3, depending on the location of your ulcers, for example, if it's near sphincter areas, like the pyloric opening. Remember, when an ulcer heals, it scars, and the tendency of scar is to pull on the adjacent normal tissue, thereby contracting the entire area. Now, if you have a lot of scar tissue crisscrossing the area, or if the area contracts because of the presence of the scar tissue, then you may actually form gastric outlet obstruction. Now, how to diagnose these patients? Granting that you have a suspicion that this patient has an acid-related problem and you suspect that the patient may have an ulcer, we employ either radiography or endoscopy. Now, the older way of doing it was through radiography, through barium studies. The sensitivity of older single contrast studies was up to 80%, double contrast studies up to 90%. The sensitivity is decreased for smaller lesions, previous scarring, and post-op patients. And up to 8% of gastric ulcers that appear benign on radiography may be malignant on endoscopy or surgery. So what is the concept here? Why all this? For you to understand all that data, all you need to know is this is how you diagnose an ulcer via barium procedure. No, so you fill up the stomach with barium, so it will look like this. No, it fills up if you have an ulcer in a particular area, that will be a filling defect. So take a look at the change in the screen. If you have an ulcer here, it will fill up. Okay, and then you're able to detect that there's most likely a crater there. No, so you see that. No, it's nowhere near the accuracy and the detail of an upper GI endoscopy of direct visualization, but that's how it was done before. Now for double contrast studies, you empty it out. No, so empty it out, and there will be some barium remaining in the defect. No, so that you can now see that, oh, that's most likely an ulcer. Okay, in actual practice, this is how it looks like. No, so this is a crater filled up with well, it has the barium has been emptied out now, but you still have the filling defect being uh, uh, occupied by the barium. No, so the diagnosis of an ulcer is there, but it is nowhere near the image of an ulcer that you will see via endoscopy. And the other thing it was mentioning was that you will not be able to tell whether this is benign or malignant. No, if it's an ulcer on top of a malignancy, you won't be able to tell. No, so sometimes you can have a diagnosis of a benign ulcer when in fact the underlying lesion is a malignancy. I won't touch now on endoscopy because we touched on it earlier, man. No? So you know what it will look like when you do the procedure. Okay. The differential diagnosis for ulcers: functional dyspepsia, proximal GI tumors, gastroesophageal reflux disease, vascular diseases, pancreaticobiliary disease, so biliary colic, chronic pancreatitis, and Crohn's disease. Now the management, okay, the treatment of these patients are divided into, say, acid suppressant drugs, but your antacids are essentially acid neutralizing drugs. Your true acid suppressant drugs are your H2 receptor antagonists and your proton pump inhibitors. These drugs address the aggressive factors, in particular the acid in the stomach. But you also have another category, the mucosal protective agents that are more addressed towards the protective mechanisms of the CISO. So you have your sucralfate, prostaglandin analogs, and your bismuth-containing compounds. Okay, so essentially this is it. So your antacids, basically the mechanism is to neutralize the acid that is already in the stomach. It doesn't do anything to prevent acid secretion. It merely neutralizes the acid that is already there. Okay. Back then, 2 generations prior, this was the main form of treatment for ulcers before the discovery of the role that histamine plays in stimulating parietal cell activity. Remember that? Huh? Remember the 4 that I mentioned. Always remember that. Acetylcholine, histamine, gastrin, and what's the last one? Somatostatin. No? And then put 1 in there. Remember the drawing of the parietal cell wherein we talked about hydrogen potassium ATPase, or what we call the proton pump. No? Okay. Presently, antacids still have a role, but they have been relegated to symptomatic relief of dyspepsia. No, very short acting, just for the immediate relief of symptoms. So examples of these are your aluminum hydroxide, magnesium hydroxide, calcium carbonate, sodium bicarbonate, and some agents may be a mixture of both. For example, your aluminum hydroxide and your magnesium hydroxide in your maalox. No? They are usually put in combination because aluminum hydroxide may cause constipation, and your magnesium hydroxide may cause diarrhea. So to offset the effects of one and the other, they are put in combination. That's why it's called maalox. No? A big advance in the management of ulcers took place when they discovered that when they had a better understanding of the 4 elements that I told you about. No, so when they discovered that, oh, histamine, if histamine is a stimulant to acid secretion, if we can somehow block that receptor, then maybe we can prevent acid secretion. And that is exactly what happened with the discovery of your histamine 2 receptor antagonists, in the form of your cimetidine, ranitidine, famotidine, and nizatidine. All of these agents significantly inhibit basal and stimulated acid secretion to comparable levels when used at therapeutic doses. They have similar ulcer healing rates. They still work, but they are not as good as proton pump inhibitors according to current studies. Taken 4 to 6 weeks with an 80% healing rate at 4 weeks. The issue lang with H2 receptor antagonists is that if you use them, it's fine for this one because you have a specific treatment duration for ulcer healing. But if you start using your H2 receptor antagonist for other acid peptic diseases like your gastroesophageal reflux disease, that may be intermittent, chronic recurrent, H2 receptor antagonists are prone to tachyphylaxis. That means that over time they might not work as effectively as you remember they did. So the effectivity wanes over time. Okay, these are the doses of these drugs. A further step forward was discovered with the understanding of the proton pump, the hydrogen potassium ATPase pump, and its role in acid secretion. So now you had the proton pump inhibitors, which are currently the standard of care in the treatment of peptic ulcer disease, as well as most, if not all, acid-related problems, including gastroesophageal reflux disease. So the first drug was omeprazole, and then you have other drugs, pantoprazole, lansoprazole, rabeprazole, esomeprazole, and you also have mirror images of these drugs. So you have your dexlansoprazole, and you have your esomeprazole is an isomer of omeprazole. Now, proton pump inhibitors covalently bind and irreversibly inhibit hydrogen potassium ATPase, and it's able to inhibit all phases of gastric secretion. Basal and stimulated acid production is inhibited by more than 95% by the time you treat these patients by at least 1 week, and the half-life is about 18 hours. So you will need to wait 2 to 5 days for acid secretion to return to normal once you stop your drug. These are the standard doses. This used to be the standard doses of your proton pump inhibitors. At present, omeprazole, the basic dose of omeprazole is now 40 milligrams per day. When it first came out, it was administered at 20 milligrams, and there was a 10 milligram capsule. That's why all your other drugs have a standard dose and have a lower dose also. So for example, your pantoprazole is given as a standard 40 milligrams per day, but there's an available 20 milligram tab. Your lansoprazole has a 30 milligram tab, but there's a 15 milligram tab. Rabeprazole is given 20 milligrams, but there's a 10 milligram tab. Esomeprazole is given 40, and there's a 20 milligram tab. Okay? So presently, especially when esomeprazole came out, they felt that omeprazole 20 milligram was underdosed. So the current standard dose for omeprazole is now at 40 milligrams per day. Now, moving on to the protective agents that affect protective mechanisms. So cytoprotective agents. So the first one was sucralfate. It's a sucrose salt wherein your hydroxide is substituted by aluminum hydroxide and sulfate. It's insoluble in water. So what happens is when you take it, when it breaks down, it forms a viscous paste which binds to sites of active ulceration. So technically, it is somewhat of a band-aid on an area of active ulceration. It's given 1 gram 4 times a day. So it's like, it's a topical agent. The next one is ribamipide. It's marketed presently as Mucosta. You also have Mucopro, Mucoprotect. It's an amino acid derivative of quinolinone. It enhances mucosal defense, scavenging free radicals, and temporarily activating genes which encode for cyclooxygenase 2, COX-2. The mechanism of action of bismuth is unclear, although it's believed that it provides ulcer coating, binding of pepsin, and stimulation of prostaglandins and bicarbonate. It's not usually used as a first-line agent for ulcer, but its resurgence, it has come back into favor due to its effect against Helicobacter pylori. So it's usually commonly used in anti-H. pylori regimens, usually the quadruple regimens. So your prostaglandin analogs, this gut to be very famous for a while. I remember I was still a medical student back then. No? It's a prostaglandin E1 derivative. And right off the bat, when you know what it is, oh, it's a prostaglandin E1 derivative, you know that there was excitement surrounding this because everything, the what you call this, the bismuth wasn't it's not mainline treatment. The because the ribamipide wasn't available. All you had were the H2 receptor antagonists, antacids at the time. So for the first time, prostaglandin E1 derivative, so misoprostol addresses the protective mechanisms in that seesaw. Now the problem lang is it has a side effect that has been abused over time. So it is an abortive agent. Now, it causes uterine bleeding and contractions. So it fell out of favor for a while. But if you look at the mechanisms, no, it's ideally, hypothetically, very good for ulcer management because it enhances mucosal defense and repair, enhances mucosal bicarbonate secretion, stimulates mucosal blood flow, and decreases mucosal cell turnover. Now, therapy for Helicobacter pylori. No? Now, if documented Helicobacter pylori presence should be eradicated in patients with documented PUD. Now, there's a table for the management. No? The regimen is usually a triple drug regimen. No? The one that we usually use is the PPI in a double dose plus clarithromycin plus either amoxicillin, amoxicillin 1 gram or metronidazole 500 milligrams 3 times a day, given twice a day for 14 days. There are of course other combinations. No, there are several triple therapies available in the market. Now, in this particular case, the standard that we usually give, no, we don't usually give metronidazole for the express purpose that number one, metronidazole is quite irritant to the stomach, and number two, it is very frequent. In order to avoid resistance against certain antibiotics, we try to avoid the use of metronidazole because it is used very heavily for amoebiasis, which is very common in the Philippines and in third world countries. This is an example of a quadruple therapy, which is relegated usually to patients who fail triple drug regimens, or if these patients fail quadruple drug regimens, that means despite being compliant, the Helicobacter pylori develops resistance against antibiotics and persists. Then a culture and sensitivity testing of the organism has to be done. Again, these are examples of salvage therapies for Helicobacter pylori infection. That means regimens that we give in the event there is failure of the initial treatment. Now, this is what I alluded to earlier regarding the treatment of ulcer, mucosal injury that is related to NSAIDs. No? So this usually comes as a case. I don't want you to memorize this one kind of flat out. No, usually comes in a case, and I never failed to include this in examination in some form. No, so it's usually like a 60-year-old female with severe joint pains, has to be on pain medications as prescribed by her rheumatologist. No, every attempt to reduce the dose or to change the medication to less irritant medications has thus far failed, and the patient will revert to being in severe pain. So the patient really has to be on NSAIDs. Now, it was eventually discovered that this patient had an ulcer. So what are we supposed to do about it? No? So here, this is how the table works. No? So if you can discontinue, the NSAID, then for a patient with active ulcer, your options are to give a proton pump inhibitor and H2 receptor antagonist. But if the NSAID has to be continued, then you put in a PPI. If for prophylactic purposes, the patient has no documented ulcer, but you just want prophylaxis, then these are your options. And of course, in all cases wherein you have Helicobacter pylori infection, the name of the game is eradication. Okay, we won't spend too long here. No? Okay, the topic is supposed to be on medical management of peptic ulcer disease, but since your chapter discusses surgical therapy, it would also be prudent for you to know about these things. So surgical therapy is an option for treatment of medically refractory disease. And it is also useful for management of ulcer complications, whether the urgent or emergent. For example, if your patient has obstruction or perforation, there's no medical management for those things. You have to have a surgeon on hand, to help you manage these patients. So for duodenal ulcer patients, usually the surgery here is designed to decrease gastric acid secretion. Okay? Because remember, we talked about this. Where is acid output higher, in duodenal ulcers or in gastric ulcers? So it's in duodenal ulcers. So that's why vagotomy is always included in the management of refractory DUs. Whatever you choose, vagotomy and drainage, highly selective vagotomy and antrectomy. For antral ulcers, Billroth 1 anastomosis is usually employed, and for concomitant DUs, vagotomy. See, vagotomy is always employed when you have DUs. Gastritis. Okay, so a patient, what comes to your mind when you say gastritis? A patient comes to your clinic, says, Doc, burning epigastric pain, hapdos akong tiyan. Maybe you have gastritis. That's the usual term that is floated around. You have gastritis when you have epigastric pain, or when the endoscopist, when I do an upper GI endoscopy and I see, hyperemia in certain portions of the stomach, or I see some shallow erosions, they would say, "Oh, you have gastritis." But the truth of the matter is that gastritis is supposed to be a histologic diagnosis. So by definition, gastritis is histologically documented inflammation of the gastric mucosa by the name itself. It is technically not erythemacine endoscopy, although it is commonly used as a term, that this patient has gastritis, and it is not interchangeable with dyspepsia. So if the patient has a symptomatic complaint pertaining the upper abdomen, then you call it dyspepsia. You don't say you have gastritis. Now, gastritis is based on the time course. So you can say that this patient has acute gastritis or chronic gastritis, and you may classify it also based on histologic features, anatomic distribution, or the proposed pathogenic mechanism. The most common causes are infectious. Okay, again, we come to Helicobacter pylori, and we talked about this, that when you have an infection of Helicobacter pylori causing peptic ulcer disease, the background mucosa is usually associated with gastritis. Helicobacter pylori induces gastritis. The acute form, however, is not extensively studied. These patients may present with epigastric pain, nausea, and vomiting, and the histology will show marked infiltrate of neutrophils with edema and hyperemia. The neutrophils pointing directly to the idea that this is really an acute type of gastritis. If left untreated, these cases may evolve to chronic gastritis. Other infectious gastritis types may also be seen in immunocompromised patients. So these infectious agents may include herpes simplex and CMV, cytomegalovirus, as seen in patients, for example, with HIV. The histology in chronic gastritis, as opposed to acute gastritis, inflammatory infiltrate primarily of lymphocytes and plasma cells, as opposed to the neutrophilic predominance seen in acute gastritis. You have these phases: the early phase, which is essentially just a superficial gastritis, which is limited to the lamina propria of the surface mucosa, followed by an atrophic gastritis, wherein you have an inflammatory infiltrate that runs deeper into the mucosa with progressive distortion and destruction of glands, and gastric atrophy, wherein lastly gastric atrophy, wherein glandular structures are lost and you have a paucity of the inflammatory infiltrate. Remember this, chronic gastritis according to predominant site of involvement. You have a type A and a type B, because usually students get these confused. Type A is the less common form. It is body predominant. So the involvement of the gastritis is usually in the body with antral sparing. And it is an autoimmune type of gastritis, meaning it is associated with pernicious anemia in the presence of circulating antibodies against parietal cells and IF. Intrinsic factor. So for those of you who are fond of cues for to memorize, no? Now, the tendency is they remember type A as antrum, no? The type A here is because it's autoimmune, no? Autoimmune gastritis. In terms of the location, the A does not have anything to, well, you can say antral sparing, okay, but you know that's not the way we use it, no? It's body predominant, it's less common, and it's associated with autoimmune disorder. So you will see that it is usually located in the body. Type B is the more common form. Helicobacter pylori is the cause, and it's termed antral predominant. Okay, so it's opposite, no? So it usually involves the antrum, but if left alone for a decade or two, it progresses to pangastritis, and the histology improves with H. pylori infection. So it mainly involves the antrum, but progresses over a 15 to 20 period to involve the entire stomach. The treatment is aimed at sequela, not an underlying inflammation. So long-term IV vitamin B12 might be needed, supplementation in pernicious anemia, eradication of Helicobacter pylori in the presence of PUD or low-grade multiple lymphoma. Meniere's disease is a rare entity characterized by large tortuous mucosal folds, often prominent in the body and fundus. So you remember the rugae, no? Large, try to imagine you balloon them up. That's what the image will be. I have a picture, no? Histologically, you see massive foveolar hyperplasia, wherein surface and glandular mucous cells replace most of the chief and parietal cells. No, so mucous cells secrete what? Proteins man ang proteinaceous material ang secretion, no? So mucous cells replace the chief and parietal cells. Okay, so it will look like this one. It's just an overblown picture of your rugae. The etiology is unknown in adults. It's suggested that CMV may be the etiology in the younger age group. You know, the presentation is indistinguishable from other dyspeptic presentations. You know, so you'll have epigastric pain, nausea and vomiting, anorexia. The peripheral edema and the protein losing enteropathy are suggestive in terms of trying to diagnose these patients because of the protein loss. You know? Occult GI bleeding, weight loss, and reduced or absent gastric secretion. The diagnosis is established by endoscopy when you see those large folds with deep mucosal biopsy and cytology showing predominantly mucous cells instead of the normal parietal and chief cells. Medical therapy has yielded varying results. Okay, if your patient does have ulcers, however, then the treatment is still standard treatment. The EGF inhibitory antibody cetuximab has been looked into, and total gastrectomy has been employed in severe cases when there is persistent and substantial protein loss despite best therapy. This is probably our last topic, no? So I'm right on schedule for 10. Zollinger-Ellison syndrome. No? When we say syndrome, then that means it has certain components. No? Number one, a non-B cell well-differentiated neuroendocrine tumor, gastrinoma, unregulated gastrin release. So you can expect, you know what gastrin is. It's a stimulant to acid secretion, and therefore the next line is expected, gastric acid hypersecretion. And because of gastric acid hypersecretion, then you will have peptic ulcer diathesis, no? Mostly in the form of erosions and a lot of ulcers in the stomach. Okay, so the pathophysiology is hypergastrinemia, stimulated acid secretion, and the formation of peptic ulcer diathesis, erosive esophagitis, and diarrhea. The tumor 80% of tumors are found in the gastrinoma triangle, which is a triangle formed by the confluence of the cystic and common bile duct superiorly, the junction of the second and third portion of the duodenum inferiorly, and medially the junction of the neck and body of the pancreas. (50 to 75% of gastrinomas are found in the duodenum, which is the most common non-pancreatic lesion, and more than 60% of these tumors are malignant. Peptic ulcer is the most common manifestation. What makes you suspect usually that this might be Zollinger-Ellison syndrome is the appearance of multiple lesions or multiple ulcers in the upper GI tract. It may be unusual locations, ulcers that are refractory to standard therapy, ulcer recurrence even after acid-reducing surgery, ulcers with frank complications, and ulcers without Helicobacter pylori or NSAID ingestion history. Diarrhea is the next most common manifestation, and gastrinomas can develop in the presence of the Menuan syndrome. The diagnosis of Zollinger-Ellison syndrome starts with obtaining a fasting gastrin level. Okay, this needs to be confirmed. So you have to assess acid secretion via endoscopy or NGT aspiration of the gastric fluid. A pH less than 3 suggests a gastrinoma, and a pH more than 3 does not exclude a gastrinoma, and formal gastric acid studies must be performed if available. Tumor localization, you have maybe via abdominal CT, MRI, Octriscan or PET-CT, EUS, and endoscopic exploration of the duodenum, and you must exclude metastatic disease in these cases, and as well as you may opt to do an exploratory laparotomy with intraoperative ultrasound or transillumination. The goals of Zollinger-Ellison syndrome treatment are ameliorating the signs and symptoms of hormone overproduction, curative resection of the neoplasm, and control of the tumor growth if there is metastatic disease. PPIs are the treatment of choice at doses higher than those for GERD or PUD. Surgery is an option. Metastatic disease is managed by timed medical management, biologic therapy, systemic chemotherapy, hepatic artery chemoembolization, debulking surgery or liver transplantation for hepatic metastasis. The overall 5-year survival is 62 to 75%, the 10-year survival 47 to 50%. But based on tumor resection, if you're able to fully resect the tumor, then your 5 and 10-year survivals are more than 90%, which is quite good. In incomplete resection, 5-year survival of 43% and a 10-year survival of 25%. But if your patient already has metastatic disease, your 5-year survival is less than 20%. Okay, so I think, yeah, we're on time. Does anyone have any questions or anything you'd like clarified before we wrap up?
None for me, Doc.
Wala. Okay. So please do not rely on this lecture, even if nag-screenshots mo sa slides. I don't usually hand out my slides, but I know that some of you like to take screenshots. I would suggest that you study the material. Please study the material, and then everything that comes out in the exam is actually in the text. The chapters are not long at all. Okay, they are quite decent in terms of length, and the level of difficulty of the material is actually quite easy. Okay. Once we come to alcoholic liver disease and complications of cirrhosis, now that's a more complicated and difficult topic, but this should be quite easy for you. So I'm expecting all of you to do well in the examinations. Okay. So if there are no further questions, then I think we can wrap up for now. So I'd like to thank you all for your kind attention, and good luck and God bless you on your exams.
Thank you, Doc.
Thank you, Doc.
Thank you very much, Doc.
Thank you.
Doc.
Thank you, Doc.
Thank you, Doc.